Welcome to today's town hall on the topic of mental health awareness. I'm Kara McNamara, Catholic Prison Ministry Coalition's Communications Manager, and along with Karen Clifton, our Executive Coordinator, and Courtney Malloway, our Program Manager, we will be your hosts for today's town hall. We are privileged to be joined by Katherine Sheffield of the USCCB and Ron Jackson and Ben Wortham of Catholic Charities USA for this important conversation to be having during Mental Health Awareness Month. Before we begin, though, let's take a moment to join in prayer. This prayer is from the Diocese of San Jose's Mental Health Ministry. Heavenly Father, your Son Jesus' public life was a ministry of hope and healing. And as Catholics, we hear your call to provide that same hope and healing to others. We pray that all may recognize the sacredness of every human life and understand that a person's dignity cannot be diminished by mental health concerns. Loving God, we pray for people who are confronted by the sadness, ambiguity, and confusion of mental health conditions. And we pray too for those who compassionately care for them. Help us to attend to those in our midst who suffer through our ministry and to work together with loved ones, mental health professionals and organizations, and all who engage in and advocate for this important work. We pray this through Christ our Lord. Amen. Thank you all for being here today. Now I'm going to hand it over to Courtney Malloway, who will introduce our presenters today.
Wonderful. Thank you again. It's my privilege and honor to introduce our speakers. First of all, we have Katherine Sheffield. She's a lawyer and serves as policy consultant to the Office of Domestic Social Development at the United States Conference of Catholic Bishops. Her policy work includes criminal justice, the death penalty, and healthcare. She has also worked extensively on USCCB's National Catholic Mental Health Campaign. She received her law degree from Boston University, and prior to her work at the USCCB, she was a litigator in California and Virginia. Her work included advocacy on behalf of survivors of domestic violence and vulnerable children. We also have Ron Jackson, Sr., joining us today. He is the Senior Director of Government Relations for Catholic Charities USA, with his primary responsibility of legislative advocacy on issues impacting the elimination of poverty. He represents CCUSA before Congress and the White House. He received his law degree from Antioch University of Law, his MSW from Howard University School of Social Work, and a BA in sociology from Jackson State University. Prior to joining the staff at CCUSA, Ron served for 15 years as the executive director of the DC Catholic Conference for the Archdiocese of Washington. And finally, we have Ben Wortham. He's the Vice President for Behavioral Health Integration at Catholic Charities USA. Ben leads CCUSA Integrated Health Strategic Priority by providing technical support to 168 Catholic Charities agencies across the country. He's currently helping to lead a national initiative called the Healthy Housing Initiative, working to reduce chronic homelessness and provide wraparound health services in 5 major cities across the U.S. Prior to CCUSA, he worked building homeless housing and healthcare programs at Catholic Charities of New Orleans. Ben is a licensed social worker and has his master's from Tulane University. So welcome, Katherine, Ben, and Ron. We're so grateful to have you here with us. And Katherine, we'll invite you to get us started.
Thank you, Courtney. And it's just always such an honor and a pleasure to be with you folks doing such important work. Like Courtney said, I work for the U.S. Conference of Catholic Bishops. I do a lot of work in the criminal justice and healthcare space. And so I'm just going to be giving kind of a brief, kind of high-level overview of what the bishops have said on healthcare and mental health specifically, and then criminal justice, and then how those two things come together. But first, very quickly, and I know CCUSA will be covering this more in depth, but why does it matter? We're in the middle of a mental health crisis. According to SAMHSA, while 18% of the general population faces a mental illness, it's estimated that 44% of those in jail and 30% of those in prison face a mental illness, and that's data from the DOJ's Bureau of Justice Statistics back in 2012. So it's a little dated. That's kind of some of the best data we have. But we know that those rates have increased, and it's not 18% anymore of the general population. It's 1 in 5, and some studies say it's 1 in 4, at least 1 in 4 adults. And then sometimes we talk about mental health and substance abuse disorders together. Those rates they're kind of staggering when we look at those in incarceration. An estimated 63% of individuals in jail and 58% of individuals in prison struggle with a substance abuse disorder. And we're mostly talking about incarceration today, but the reentry period is also very relevant. And individuals reentering society are 129 times more likely than the general population to die by overdose within the first 2 weeks. So for those in incarceration, and then when they reenter society, healthcare is just absolutely essential. So I just kind of wanted to give that as a backdrop kind of to our discussion today. So where does Catholic teaching and the bishops specifically, where do they come in? So the Catholic Church has long taught that healthcare is a human right. We see this very beautifully explained in the encyclical Pacem in Terris that was written by St. John the 23rd in 1963. And it talks about human rights in general and specifically healthcare. So the bishops in the United States have long advocated, healthcare is a human right, full stop. And I'll quote them here. This right flows from the sanctity of human life and the dignity that belongs to all human persons who are made in the image of God. And so when it comes to healthcare policy advocacy, the bishops have developed these kind of 4 bedrock principles. And we have, on many occasions, written to Congress on various aspects of healthcare, how applying and encouraging Congress to apply these 4 principles. Those principles are respect for life and dignity, honoring conscious rights, that healthcare should be truly affordable, and that healthcare should be comprehensive and high quality. Momentarily, I'll drop several resources in the chat box for you all, and I will include a very recent letter just from a couple weeks ago. We wrote a letter on maternal health, and we use those 4 principles. So just if you're kind of interested in how we apply those. Mental health in particular, it just matters so deeply to the bishops. They see their parishioners struggling. And this last fall, the USCCB launched the National Catholic Mental Health Campaign, kind of in collaboration with several other Catholic organizations. And I will drop a link to that as well. But there's kind of 3 general or major tenets of the campaign. One is we need to raise awareness. 2, we must combat stigma. And 3 is advocacy, so that everyone who needs help receives help. And there's a few different facets of the campaign. And that does include some roundtable discussions where bishops have been able to kind of really go more in depth as to various aspects of the mental health crisis. So again, I'll include that link as well. And at the November Assembly of Bishops, there was just such a resounding conversation, just kind of bishops across the United States saying, yes, we live in a mental health crisis and we need to do something about it. So then turning to kind of what about mental health care, particularly and criminal justice, the bishops have long advocated for restorative justice. Criminal justice is something that's actually rehabilitative and restorative. And they have said very explicitly that we must respect the right to healthcare, the human right to healthcare of the incarcerated. The bishops wrote a very beautiful document. It's called Responsibility, Rehabilitation, and Restoration, a Catholic Perspective on Crime and Criminal Justice, back in 2000. I'll, again, drop the link to that. But they discuss this, the inherent dignity of every person and the inherent dignity of those in incarceration, and just the need that they receive healthcare, receive healthcare that's comprehensive and high quality and that respects the life, life and dignity of each individual person, because we're all made in the image of God. So kind of a few other things. I did just want to briefly touch on solitary confinement, which we know has, deep impacts on mental health. And in that same document, the bishops did, kind of speak out against the increased use of solitary confinement and noted its effects on mental health. And Pope Francis has called solitary confinement a form of torture. The bishops have also, for many years, worked extensively in advocating for more resources and holistic resources across the board for those in reentering society, and have spoken very purposefully of the need for more mental health treatment and substance abuse treatment for those reentering society. So again, just kind of taking a step back, the criminal justice reform and mental health care does matter very, very deeply to the bishops. And they've spoken on these topics at length for a very long time. And it's all rooted in the dignity of the human person. In terms of kind of what action steps there are, the USCCB on our website, you can sign up for action alerts. And you can also go on our website to kind of see what specific pieces of legislation we have advocated for in the past and anything that is forthcoming. I would also encourage you, a lot of criminal justice reform, as well as healthcare, takes place at the state level. So just always, reach out to your local state Catholic conference and to see what, legislation they're advocating for as well. Thank you, Courtney.
Thanks so much, Catherine. And I'm sure Catherine will put all those links in the chat for us. So if there was anything that piqued your interest, please, feel free to follow those links. I'd now like to introduce Ron and Ben to come and share a little bit from Catholic Charities USA.
Yeah, you go. Yeah, well, welcome everyone, and thanks for that wonderful introduction. It was nice, short, and brief. I wish I was as old as that nice, short, and brief, but I've been around a while. And I just wanted to share a couple points, because I think I was asked to address the whole concept of how we advocate and, as some people say, lobby. I was just thinking when I was hearing the introductions and everything, and the whole purpose of this, I was in a meeting with Reverend Jesse Jackson, old friend, back 25, 30 years ago. And I'll never forget, he asked everybody in that room, he said, can I see a show of hands of anyone in the room that has had a family member in the criminal justice system? And it was about 90% of the room, hands went up, maybe 95%. It was astonishing. And I never forget that, because I think sometimes, we just forget it's family that's impacted by the criminal justice system. And, it really hits home when you got family members that are caught up in this. I had a nephew on substance abuse, and but thank God he got out, he's rehabilitated and doing extremely well. Okay, so I know there's hope, and I know that the work that we do within our different organizations make a difference. Now, when I was just alluding, I went to work on Capitol Hill August 23rd, 1974. Isn't that amazing? I was very, very young. I keep saying that, I emphasize that. and actually, the only person that's in elected office now, when I came to Washington, is President Joe Biden. Wow. He was a junior senator. He had just, I guess, in his second year. And so there's nobody else around. Now, there are a couple of members, I believe, who were staff members back then. I've been around, I've seen a lot. I probably can show the architecture of the Capitol, a couple of places up there they don't even know about. But look, our ability to, our right to lobby, to be advocates, is a constitutional right. It's given to us, and it's right that we use it, okay? And there are some fine line distinctions between advocacy and lobbying. I think a lot of times people get a little caught up in that. And advocacy, I would just plain simply say, is the ability to influence on a bigger scale. That's when we send out action alerts and all those kind of activities, asking people to weigh in, to get their members of Congress to take a position on a specific bill that we're pushing. Lobbying is the direct going into that legislative office face to face and trying to get that office, that member of Congress to support the bill. And that requires a lot of work, because I think a lot of times when people get involved in the advocacy lobbying, or specifically the lobbying, there's two simple things that I think we sort of take for granted. One, you should know who you're going to be lobbying. And two, you should know the issue that you're going to be lobbying for. And now people say, oh, wow, that's a given. No, it's not necessarily. Because a lot of times bills are dropped and we don't have the right committee of jurisdiction. Then we have to fight to get the bill in the right committee of jurisdiction. And then we have to fight to work to get the legislation where we needed to be to meet the needs that we have to have met. And in this area, I'm telling you, it's a real tough area. In criminal justice, it's all over the place. So the other point that I want to emphasize is know the politics of the issue that you're lobbying. Because, I mean, what we've seen with the Second Chance Act and some of the other legislative pieces that we've been trying to get behind and push, if you don't know the politics, I mean, you can almost forget it because the politics will eventually decide the outcome of the legislation. And on that other point, this is just sort of like a last point. Never get discouraged about not getting the bill done. I've worked on, civil rights bills. I've worked on, I remember fair housing. We got fair housing done. It was initially done in 1968, went until 1988. It took 20 years to get the fair housing amendments done. So I hope it doesn't take 20 years with a lot of criminal justice reform that we need done. But I'm just saying that, things have to be aligned. You got to have the right people that's on the committees, especially the committee chair and the ranking committee members. You can't get to know those people and their staffs enough because they're the ones that's going to write the bill and they're the ones that are going to lobby the other people on the committee to get the bill out of committee so they can get it to the floor. So know the politics. And another critical point of the politics is like the Rules Committee. A lot of people overlook the Rules Committee because you can get a bill out of committee, but you can't get the rules, and that coincides with the leadership of both the majority and the minority. So I guess the last point that I want to make is, as I've said, I've worked on so many pieces of legislation over my career. There were times that, we said, oh gosh, we're not going to get this done. And then all of a sudden, a bright light shines. Even though the political times we're in now sometimes can be very disappointing and disheartening, there are windows of hope. And I think what I always encourage is that we just never give up. You got to keep pushing. And this Congress, for the most part, I think this legislative session is pretty much done. And I think once the elections are over, we get a new Congress that starts January 3rd. It's the new beginning. I don't care who's in there. You just got to continue to keep working to get bills done. I've done a lot of work in the past on the whole death penalty issue. I've seen a major transformation over the years on that issue specifically because there were times when we thought, it will never happen. And again, I appreciate what was said earlier about state by state. A lot of stuff is done on the local level. That's where you begin to get your grassroots. And once you get to the grassroots, you can move on to the big issue. Now, Ben is going to share what I say is the stuff that helps you make the sale. Because when you've got the data and you've got the facts and you can show members of Congress, especially one last thing, one of the things that we have in our government relations is we have a district and a state breakdown on data in those particular members and their states. And it's data that talks about the level of poverty, talks about the number of services that our Catholic charities provide. And once members of Congress and staff people see that, their eyes pop open because we're giving them factual information and facts. It's a one-page piece, and maybe we can share that and just show you an example. At some point in time, we can send that out to you guys. It's extremely helpful. So when you got the facts like Ben is giving to give you, Ben has it. Let me tell you what, this is a mental health guy. He knows exactly what he's talking about. And I mean, I threw in my hat a long time ago from doing social work therapy years ago. Ben knows what to do. I'm done. Let him talk.
Cool. Yeah. Thanks, Ron. Thanks, Catherine, as well. Yeah, let me share my screen here. I like to think Ron and I make a good team. He's got the history and the policy down, and then my role is more programmatics, but really get to learn the policy through conversations with him, and we kind of put our heads together and kind of figure out issues. So a lot of time spent with our 168 Catholic Charities agencies, figuring out what's going on the ground level. And I actually spent years working on the ground level in homelessness and healthcare. Let me see if I can pull up this. All right. Okay, so I'm just going to give sort of like a little bit of a story and then some data and really connect this to homelessness, because there's no way to remove the issue of homelessness from this issue of people incarcerated who are let out, the reentry work. I feel like it all blends together with this mental health crisis that we have going on. So I know a lot of you probably know this. I just put this, we can share these slides again so you can have all this. 70% of unsheltered homeless report of history of incarceration, 70%. That's just unbelievable. Formerly incarcerated people are almost 10 times more likely to be homeless than the general public. And then research suggests that 15% of incarcerated people experiencing homelessness the year before they go to prison. So my little just story, and I'm going to take sort of like all of this is through like a Catholic Charities lens here. So I worked at Catholic Charities in New Orleans for 7 years. A bunch of those, I would consider myself a street outreach worker. I was on what we call the street medicine team. This is a photo that I took, and we would go into each encampment and really rotate the ones we went into. And we would actually enroll people from the tents into our program and try to wrap around healthcare, behavioral health, social services around them. But one of the takeaways that I had in these encampments was probably, I think, with our data some years back, about 60% of the people in these tents that we went up to over the last couple of years had been recently released from prison or jail, which was staggering, which I had no idea going into it. And so when we would do these street medicine walks and go around to the tent, so we had a physician, a person from EMS, a police officer who was like the friendly police officer who dealt with the homeless, and then oftentimes me. And so when we first started these street medicine walks, going tent to tent, I really thought that every single person in these tents, like the whole thing to me, it was called street medicine. We were there with the doctor who was kind of front and center. I was basically told myself going into this, like, don't say hardly anything, just try to learn like what's going on. And but what ended up happening was we would go tent to tent, and I swear like 9 out of 10 people would be like, no, doc, like I'm not sick, I'm okay, but like go see my friend over there. And like they would all actually try to pawn the doctor off onto their friends, and then we'd go see the friend, and the friend would recommend us to another tent. But who did they like? Probably 9 out of 10 didn't want to see the doctor, although definitely almost everyone we went up to was pretty sick. But they all wanted to see the person that could help them with social services. So in their minds, even though they were sick, that wasn't the need. The need was, how can I find my case manager to help me with housing? How can I get SSI? Why did my food stamps get cut off? Every practical reason you could ever imagine that was front and center on their mental health. So again, I want to make the point, even though they were all sick, and if they weren't sick now, they were going to be sick, the doctor and the hospital and the physician wasn't what was front and center for them. It was what they wanted to work on, and what they were thinking about were the social determinants of health, and really the programs that Catholic Charities New Orleans, which is the largest nonprofit in New Orleans, at least at the time, could offer. I think it was about $35 million budget at the time, and we could help with a lot of these issues. And so that's sort of just like a window into when you think about what's going on with the mental health and what's compounding these mental health issues, because people do have mental health issues, depression, anxiety, but a lot of it stems from a lack of resource. So this is a slide and a couple of slides we showed to CEOs of hospitals and insurance companies when we try to get their attention. So when you look at this right here, we say this is a client's breakdown of their health, but also yours. And so this is what makes up, and the whole healthcare system is getting to know this right now. This is catching on like wildfire. And so what this shows you is 20% of what makes up your good health is clinical care, going to the doctor, following up. But that's only 20%. What really makes up good health are your health behaviors, 30%, and then your social support, income, employment, education, housing, transportation, quality of air and water, which I think makes a whole lot of sense to us. But yet we invest so much time and energy into what we just call healthcare. I think sometimes we forget what really makes us healthy and what is really healthcare. And this is that same pie chart, but it's put through a Catholic Charities lens. And so I always tell people, if you forget what Catholic Charities is and what we do, just remember what the social determinants of health are, and then you remember what Catholic Charities does. So we literally make an impact. We have 1,500 programs and services across the country, and every single one of them impacts housing, income, employment, education, family, social support, community safety, access to food, transportation. Those are the social determinants of health. And so really what we've been trying to do over the last 5 years, at least since I've been at the national office and in some of these national initiatives and with mental health, is we're trying to figure out, since 50% of what makes up your good health are these social determinants of health, which actually equal good mental health in combination possibly with the therapist and or social worker and your clinical support. How can we, if there's $4.3 trillion in just this 20%, how can we figure out? So 1 out of every $5 spent by Americans in 2022 was just on their healthcare, which if you think about it, doesn't make any sense, because it's really these issues that Catholic Charities can support people on that actually make a healthy person. The average person in America only spends 1 hour a year in primary care, 1 hour a year in this 20%, yet we have $4.3 trillion. So one of my roles at Catholic Charities is to figure out how can we partner with this 20% and figure out models and ways, and what can we do policy-wise to try to pull money out of this 20% of good health and put it back into what really makes people healthy, which are these 50%, which are these areas that we know are. I just want to make this last point. If somebody's homeless, I've met incredible doctors at Healthcare for the Homeless clinics around the country. It doesn't matter how good the doctor is or how good the clinic is if the person leaving the clinic exits that clinic and goes back out into no housing, no income, no employment, no education, family social support. So this is a slide we show to hospital CEOs, but also to staff around the country at Catholic Charities to let them know, like, you literally are mental health care. When a person doesn't have these things on the right, then that's compounding mental health, the mental health issues that they have going on. So I want to just dive, and hopefully this stays practical, into just, and this is actually a shout out to USCCB and Julie Bodner, who put these slides together for these presentations we've been giving around the country on homelessness. To really get people's attention and advocacy for it, and all directly relating to the mental health crisis. And so this is the most recent numbers of homelessness. It went up by 12% from last year. So what this graph is showing is, and this is the COVID year right here, the COVID years with a little lack of data. But what this is showing is in 2022, this blue line is the total. There were 582,000 homeless people. In 2023, on the last count, last January, it was 653,000. So a 12% increase in the people who, and that number is most likely low. And so the total homeless, this blue line is is this gray line, which is sheltered homeless, which is about almost 400,000. And then about 300,000 is the unsheltered. So about 60% of homeless population are sheltered in shelters, and 40% are totally unhoused on the street, and the people that you're seeing right now. Just as sort of an FYI, these are your states that have the worst homeless population. So look at California, 181. That's your leader. So the top 5 are California, then New York, then it goes to, I believe, Florida, Washington State, and Texas as your top 5. So this is, so 31% of all homeless individuals are chronically homeless, which means they've been homeless for a year or more. So this graph is the most alarming, one of the most alarming things I've ever seen. And again, goes hand in hand with the mental health crisis. So just listen to these numbers real quick. So in 2022, there were 127,000 people who had been homeless for over a year, is what this green line is showing. In 2023, 16,000 more people became homeless, which meant they hit the streets, and those people had basically graduated into a year or more of homelessness. And so this is the alarming part. So this green line shows that there was a huge rise in the number of people who had been homeless for over a year, which if you've been homeless for over a year, it's a lot more likely that you're going to be arrested and go to jail and get caught up in this whole system, right? So the longer it goes on, the more likely that becomes. The wild part about it is that this new population of people becoming chronically homeless for over a year literally mirrors the line of people who are living unsheltered. So almost all of the new people who've been homeless for over a year are not being housed, or they're not going to shelters. They're literally hitting the streets, which explains why we're seeing this issue like totally like magnified in a lot of our cities because it's quite literally these people are on the streets. They're not staying in shelters, any of the new ones. And so oftentimes when somebody's released from prison and they're caught up in the system, the best housing for them is called permanent supportive housing. And what that means is you have housing with a case manager support. So it works really well. I think we have like a 90% retention rate. It's like the gold standard in housing the homeless. And many of them have mental health issues. And 70% of those, of course, had been caught up in the criminal justice system. So there's almost 400,000 people. There's almost 400,000 units. This gray line is permanent supportive housing units. But I just want to make this point that from 22 to 23, we only developed about 8,000 more units of permanent supportive housing, which is the type of housing oftentimes that people need when they're in that reentry phase coming back into the community. But the problem is you see, we're not developing permanent supportive housing very quickly. And I work on a national initiative trying to develop this because we're not developing it very quickly. As quickly as this line, you see these lines of homelessness are shooting up of people who are super sick, homeless, living on the street, and we're not keeping up anywhere close to the amount of units that we need to support this population with housing. And so what's ending up happening is that a lot of them are getting stuck in this green line, which is emergency shelter. You can have all these slides. So just a couple numbers for you, and these came from Kaiser. So there was about almost 500,000 people that were released from prison in 2022, which makes a whole lot of sense to me going back to these numbers as those numbers keep happening and there's nowhere for those people to go. There's a direct correlation between people being released from prison, that number 500,000 a year, 500,000, 600,000 with no affordable housing, and these numbers skyrocketing right now to the tune of 653,000 people who are homeless right now. So let me explain this real quick. And this, of course, is intensifying the mental health crisis that's going on. I think our affordable housing crisis plays right into what we're seeing nationally and with a lot of these other trends, and especially this mental health crisis. So this was really interesting to me. It's something that I've actually learned over the last 6 months. So look at this extremely low income bar graph right here. So this means people with extremely low income would be people that make them are at the poverty line or below. So what this means, what severe cost burden means, is that 73% of people who are extremely low income, which are many times people recently released from prison with maybe a minimum wage job or just SSI, 73% of them that can find housing and are in housing, 73% of extremely low income individuals pay 73% or more on, sorry, let me say that again. So for people that are extremely low income and are renting, 50%, what it means is 50%, you pay 50% or more on rent. So let me say that one more time. Sorry, I got tongue-tied there. So 73% of people who are extremely low income pay 50% or more on their monthly rent. So you can see, so this line is really, really awful. And the reason why people recently released and are trying to get reintegrated into the community have such a hard time saving, because we see that 73% of extremely low income renters are paying 50% or more. So severe cost burden means you pay 50% or more of your monthly income on rent, and cost burden means you pay 30% or more a month on rent of your monthly income. Sorry for the fumbling there. All right, and then this is just to show you where we're at. So since 2001, the median rent has gone up almost 20%, yet the median renter income household has only gone up 4%. So all of this plays into the mental health crisis. It's not sustainable, and it makes it very hard, especially for people released from prison. And so this is what it costs in your state. This is what you need to make an hour to afford a market rate apartment, 2-bedroom apartment in this state. So as an example, in Texas, you need to make $25 an hour to afford a 2-bedroom apartment. In California, you'd need to make $42 an hour. And we know $42 an hour just isn't realistic for a lot of people, especially who have been homeless or in a mental health crisis or recently released from prison. So here's more of a hot topic that maybe some of you know and some of you don't. We're really getting to learn. We've been learning it over the last couple of years. So this is what's called the 1115 waiver. There's a new 1115 waiver, reentry waiver. It's a Medicaid waiver, so it comes down from HHS to CMS. So CMS, Centers for Medicare and Medicaid, released this waiver. So what this means is, 3 states are implementing this waiver right now, this reentry waiver. And so California, Montana, and Washington all have it going live right now, which means, and this is something to absolutely support, which means people being released from prison or jail, it looks like for Montana, just prison, they receive Medicaid 90 days before they're released. And so, and in Washington state, 90 days as well before they're released. In Montana, 30 days before they're released. And so what that means is now you can receive from Medicaid all of these benefits before you're released. And so you can start to get reintegrated before the 90 days before, which is a huge deal. So you don't hit the street without Medicaid or insurance and you can get involved. But part of the issue with it now is that the prison system, now that this has been implemented, this waiver in these states, they have to figure out how do the prisons, how do the jails make form community collaborations with people like Catholic Charities to help do some of these services like medication assisted treatment, counseling services, case management. How do they partner with community-based organizations to help do a lot of these? And that's sort of where we're at now. A lot of this stuff is just being piloted, but I think we can absolutely keep advocating for the need for people to get services and linked to healthcare and Medicaid 90 days before they're released, absolutely, with that waiver. So this is what the waiver looks like right now. So it's been approved in Montana, Washington, and California, and then it's pending in these blue states. These are the 19 states that this waiver is pending in. And these are Ben and Ron's practical solutions to support those returning home and really to support this mental health crisis we have going on. So the first one is support the 1115 waiver we just talked about. The way you can support it is by calling and trying to jumpstart it in your own state, potentially. And so the way you do that, and you can get with us about how to best do that, but you'd actually call your state Medicaid office. And we've talked to national CMS on how to do that. Affordable housing, absolutely support any building of permanent supportive housing like we talked about. We know that you can't just house a lot of these people who have mental illness and are on the streets. You have to house them with case management and wraparound support, something Catholic Charities is doing really well. We just need a lot more of it. And so we have to keep advocating for it. We want to keep supporting behavioral mental health telehealth. This has been one of the best things I've seen go on in the 5 years. And when we started during the pandemic, I never would have thought we had, I think, 60 counseling programs across the country that all created basically in like a couple weeks' time a telehealth component to what was their in-person counseling program. So the telehealth boom, we have seen that explode in our Catholic Charities network, and huge advocates for it. And we've seen a lot more people receive mental health healthcare because of telehealth. And I know it's a big issue right now with funding and what's coming down the pipeline with the bills. And we have to keep supporting. So we want to support low barrier access to telehealth indefinitely. And then this is one that some of you might know about. It's probably one of the ones we talked the most about recently, at least. And this is a big one, which is to support the increase of Medicaid fee-for-service rates. So for those who don't know, if you're a counselor and you take Medicaid, so you see the most vulnerable and the poor in America, and you provide counseling to them, the rates are very low and they're not sustainable. So what's happening is our Catholic Charities agencies and community-based organizations are providing counseling and they're billing the clients Medicaid, but they're literally having to subsidize millions of dollars of their own money across the US right now, where our Catholic Charities Network is subsidizing Medicaid rates to the tune of millions to be able to provide the service. So we shouldn't be subsidizing insurance companies to be able to service the poor. And that's what's going on. And then this is one we just generally see and hear a lot about from the RCC network, and that's support the need for more substance abuse services to take Medicaid. I think we have a lot of substance abuse services and programs popping up. The issue is that most of them seem to only take private insurance or private pay. We have to have more that accept Medicaid. So it feels like a case of if the people who have the least, again, are able to have access to the least, when I think Medicaid should really step up and we should really work on creating programs where people can have access to substance abuse services with their Medicaid. And then a big one to advocate for is Medicaid expansion. I was in Louisiana when Medicaid expanded, and I can tell you I was working in a homeless apartment building, and I call it health insurance Christmas. It was like every single homeless person was mailed an insurance card and came down to my office and our offices, and they're like, I got Aetna, I got Blue Cross Blue Shield. And they were super excited because for many of them, it was the first time in 10, 20 years, maybe in their whole adult life, that they ever had insurance. And like right then and there, it was like, okay, let's call the local clinic and you can get in for primary care. And I saw what it did for the health of New Orleans when Medicaid expanded. And so through that experience, like I know what's going on when Medicaid expands for the poorest. And so if we can make a policy push, absolutely we want to keep expanding Medicaid. There's 10 states left, these orange ones, Texas and Florida specifically, we got to keep working at to get Medicaid expanded in those states and get everyone healthcare. And so I'll end with like a couple things real quick. It's just the racial disparities in all this cannot be ignored. And so here's a big one. So people who identify as Black African-American make up 12% of the general population, yet they make up 36% of people incarcerated in federal and state prisons, 36% of people incarcerated in jails. What is really mind-blowing to me, because I was looking at these numbers and then comparing them, because I was like, well, what is the homeless? Like if African-Americans, people who identify as Black are 36% of our state and federal prisons, what does the homeless look like? Now, this, again, you can have these slides, but look at this number right here with African Americans who are homeless, 37%. So what that means is it literally is mirroring this exact number of people who are incarcerated, that exact percent are homeless, which makes no sense that that would be the case when only 12% of our US population is Black. I don't understand how that happens. And obviously, that's a whole other webinar town hall. And this is positive for you. Almost done here. This is Catholic Health Association's map. And so all the red dots you see and all the blue dots are Catholic Health Association facilities. All the red ones are hospitals across the country. And one of my jobs is, and I've been working with Ron on this, is these yellow dots are Catholic Charities agencies. And so when we present to CEOs of hospitals or CEOs of Catholic Charities, we say, if you see a yellow dot and a red dot that's close by, which there's tons of them, then we're really pushing for, and we want to help you create a partnership where there can be a big time, robust collaboration. As an example, where you could possibly refer clients to primary care and mental health services at the local hospital that's right down the street from your Catholic Charities. And so we're trying to jumpstart this integrated health model to help this mental health crisis that's going on with social services. And this is the very last one to make you mad. So this should be actually a hopeful slide. So I call this slide Untapped Potential, because in America, like I said, we have $4.3 trillion in the healthcare system. We are absolutely looking at the healthcare system as the solution to solve homelessness and make a big dent in the mental health crisis going on right now. The money is there. That's why we're hopeful, because other countries have issues with homelessness and a mental health crisis, but they don't have the resources that we have in America and all the funds and everything to make any type of dent in it. But here in America, we have the money in the healthcare system to, if we reroute it the right way, to solve a lot of these problems. And I just want to make this point because this absolutely blew my mind that the top 7 CEOs of insurance companies in 2022 made a combined $335 million. 7 people in the healthcare system supposed to be taking care of the poor and have Medicaid plans. So these companies have Medicaid plans all across the country. Half of everyone who's attached to a Medicaid plan, so half of all poor people who have these plans, the vulnerable, those plans are attached to Fortune 500 companies. And so what that shows you is, I don't understand how services on the ground level, on the streets, seem to be getting more and more scarce when 7 people made $335 million in the same healthcare system when homeless people and people with mental problems couldn't get any services on their Medicaid plans. So we know where the services are being cut, and it's not at the top. It's obviously down at the bottom where we need services more than anything. So I would to do the math for you. So $335 million for divided by 365 days. So this is per day. So 7 people made $920,000, $1 million a day. And so what we go around the country saying is, imagine if you gave Catholic Charities $1 million, let's say, for a reentry program, which we'll take, and what we say one conference recently is, we'll take one Sunday when you're all at church, we'll take that amount of pay. While you're there for that Sunday, we'll take that pay and we'll use that to create a reentry program to help the poor and vulnerable. I want to end with this because I think it's gross, but I also think that we have the untapped potential in America to solve homelessness, to solve the mental health crisis, to absolutely put money back into the social determinants of health, which actually is what makes people healthy. And I think if we invest in housing, transportation, everything that are the practical reasons that people have mental health problems a lot of the time, then we would all be a lot healthier. And I hope we start trending in the right direction here pretty soon. Hope some of that made sense.
It did. Ben, we want to take your energy and we want to bottle it. And then we're going to distribute it among all of our lobbyists that we've got out there. And thank you. That is so much information that we're just going to, we will definitely send this out. We'll put all the links with it and get it to everybody. We need to rewatch this a couple of times. But there's 2 points I want to lift up. And because there is so much information and what you led off with the fact that we've got this dormant season coming up. Catholic Prison Ministries, the reason we started this advocacy piece was really to engage our ministers, those with the stories like you that have been on the streets, have been in the prisons, have been in the reentry centers, that have seen this. They're the voices and they're the stories to take in. So Ron, could you just capitalize this? I know this is your expertise as far as reiterate the importance of telling the stories and being the face and doing this work on the off season.
Yes, absolutely. And I kind of pick up on Ben's energy. I can get fired up on this too, because I've seen it in person how you can make a big difference. I can't remember the name of the program. There's a program down in New Orleans, Ben, over there near Xavier University. My brother that's in New Orleans, from New Orleans, he's worked with this guy. I think his last name is Henderson. But he has a program where they have made big strides in Louisiana legislature to get formerly incarcerated their rights to vote and things of that nature, right? So I think you come up with a strategy. If it's legislation you're trying to get through, this is what I always suggest. Start big, but realize how low you will go. Okay, because a lot of times, as a coalition, we'll put a bill in, and we really don't put in everything that we need to have in there. But I always say start big, and then see how far you can push it. Because when it's all said and done, you want to make sure that you get the most essential pieces out of that legislation that's there. The other point that I think in terms of, I want to keep harping on the politics. because I think we're in this, we're in a phase in time in the country of our, in the history of our country where people just tend to think very negative, like Ben was illustrating on the poor, and especially people who have been caught up in the criminal justice system. You know, the attitude is like, well, they did the crime and they don't, you know, they're outcasts. A lot of those people come out, and if they're given the right opportunity and a chance, they will, you know, really do well. So I think as we look at the things that we need to do to ensure that our legislators, the politics, you have to show them the data, you have to show them the facts. And you have to, this is the other point, this is one of the things we really emphasize here at CCUSA. When we go into members' offices, we tell them when you go back home in the district and you're there for the district period, go into one of our agencies and see the work that we're doing firsthand. And if you particularly have, you know, criminal justice programs, go in there and show them. Now, let me tell you what that's really interesting about that, though. A lot of times, elected officials, members of Congress, they're somewhat skeptical to go out into homeless shelters and places like that. And you know why? Because they're afraid they might see somebody that they know. And it becomes mind-blowing to them because, you know, yeah, I'd have made it successful to the Congress of the United States. And there's somebody I went to high school with or somebody I grew up with in the neighborhood. And it really tears into their heart that they, you know, see somebody that didn't go to maybe the way things went for them. So all of these things I hope are helpful. You know, just don't be intimidated. Remember to remind elected officials, they work for us. We don't work for them. And that's one of the things that I think where we've made a big mistake is that we elect people after we elect them, then we leave them alone. And then they start feeling empowered that they can do and say anything they want to do. We're the bosses. Remind them, we're the bosses. Y'all work for me. And when they see me coming with my hat on, coming out all the time, they start running. They say, "Oh, like Katherine got it." I said, "I want to remind you, I'm the boss. You work for me, all right? I can go on."
No, but that is important. And Ben, you did such a beautiful job of giving so many people good information and new information. You know, especially when you brought up this waiver, the 1115. That's crucial. Because I almost wanted to push back when you were talking about all the social issues. I'm like, half of those people that are out there is because they are unmedicated. They don't have access to healthcare, mental health care. And that's the way how they ended up homeless. And so it's a chicken and the egg. I mean, you could start on both ends, but that's something that we can function. And most of the people that are released, they have no access to healthcare, and then they're immediately off their meds. So that's where our recidivism rate kicks in.
Exactly.
So it's a spiral in this circle. And so I know Karen made a comment on here as far as how can we get involved, and
so there's other 1115 waivers. It's a really cool waiver, the 1115. It basically lets you use dollars. So one quick example, our Catholic Charities in Raleigh receives referrals from the state for people who are food insecure. Like doctors literally refer through a system to our Catholic Charities. Our Catholic Charities in the morning goes into our big food pantry they have there. It's like a little mini Costco of food, fill up these food boxes, deliver them in the area to people that are already really giving food out to a lot of the time. And they get paid from the insurance company $120 a food box. They've made $1 million off of it. Literally, insurance now is paying for like the social determinants of health. So they're paying for food delivery and they're paying for transportation. They're paying for these things. So I just want to stress that because the 1115 waiver is dynamic and they talk a lot about it, but honestly, there's not a lot going on. But let me answer that question directly. So we've really put up some pressure, and I've had some meetings with some of the people here in DC about this, some of the experts on the 1115 waiver. It's a little disappointing to what Karen asked, because when we say, look, you can't just, what we're saying right now is, so when we say we want to know how to jumpstart 1115 waiver, and maybe specifically this, Karen, it would be the 1115 reentry waiver, and you can leverage the California and Washington state as the example. But But what they'll say back to you, and I honestly think it's disappointing, and it's kind of where we're at right now, is just reach out to your local your state Medicaid office and let them know. Well, I have an issue with that, and I've voiced it, which is, look, you can't just tell somebody who has no contact and know that, oh, like just to reach out to their state Medicaid office. What we need, and this is sort of the pressure we're applying CCUSA on this process, is we are advocating for a step-by-step process with a contact that we could potentially reach out to that could then funnel it down, instead of the local people in Iowa having to reach out to the office and then up to DC and then back down. And so we're advocating for a one-stop shop for this type of intervention, but that's what we're hoping for, Karen. But where we're at right now is you do what top people at CMS will tell you is, if you want this waiver, reach out to your local state Medicaid office. I wish there was a better answer. I hate that answer, but that's where we're at right now. And we're working through that.
Yeah, we'll have to, Ben will come back as soon as that is organized. If you will come back, we can just do a training on that, because I think it's important enough. And there's two other points, and I know we're running out of time, but one is housing, and we need to do just anything we can come back on for a webinar on housing, because that is such a big issue. And we've got such wonderful examples in the Catholic Church of reentry homes that have a wonderful record as far as no recidivation, because it is faith-based and empowering the basic human dignity of people. And I can count them on a hand. So we need that to be picked up and go across the country as far as that. The other is in prison. And is there any legislation on improving healthcare, mental health care within? And I can say this as a Texan, and having walked through in the prisons in the middle where they've got the air conditioning at 63, people stripped and screaming. It's like you'd think that you were back in the 20s, 1920s, the way that some of the things that you see. So is there any hope on the horizon on that?
I personally don't know. I don't know if Catherine has any. Ron, I don't think we have anything good to share on that.
No, but I mean, it's an issue you might want to start pushing out there, make it public. Because the public clearly doesn't know that's going on.
No.
It's an education issue.
Yeah, okay. Thank you. This was amazing. It's so much information, and I'm going to ask you all right here so everybody can be affirmed that, then is it possible that people can use your slides?
Yeah, I'll send them to you all right after this, and you can send them out.
Okay, and we'll include that with the presentation with your information so that they can
Perfect, yeah.
facts on that, and we'll let people know you will be back. So with more information, both of you and Catherine, and just publicly, we want to congratulate you, Ron, on your upcoming wedding this weekend, and may God bless you both, and
yes,
I'll just continue to be blessed with health and happiness, both of you.
Yep,
love never ends. It keeps going.
Yeah.
Okay.
Ron's party actually starts right now. He's a minute late, so he's got to go. He's got to go. So.
All right, guys.
Thank you all for this presentation. It was wonderful.
Thank you all for having us.
Thank you so much for being with us today. Thank you again, Ben and Catherine, and we look forward to seeing you at a future town hall and webinar.